a little bit to get through. Welcome everybody. It feels like ages since I last saw you all. I think it was ages since I last saw you all, but welcome. So today, for those of you that have just joined, just a reminder that we started recording just this first part of the session. We're delighted to have Tracy with us today, and we're going to focus a little bit on substance misuse this morning, and then we'll go into update bit after that. And I will just go straight over to you, Tracy, if that's all right.
Great, thanks Emma, and good morning everybody. I'm Tracy Goodhew. I'm the Health and Wellbeing Programme Manager for OHID, the Office of Health Improvement and Disparities for the South East, and I lead on alcohol and drugs. And so this morning I was asked to talk to you about substance misuse and homeless health. And first of all, I need to apologise. I haven't got my camera on, not because I'm camera shy for those that know me, but my laptop is playing up, and when I put the camera on, it flashes little red lights at me. So I might, I'm worried it's going to explode. So I'm going to go through some slides with you. If you've got any questions, please pop them in the chat. But there will be an opportunity at the end for any questions or a bit of a discussion. And the last slide in the pack, when we get to it, has got a couple of links for some resources that you might find helpful, as well as my email address if you want to contact me after this meeting. So I thought it might be helpful just to kind of give a very general overview of drug and alcohol treatment in the South East, an update on the Dame Carol Black review and the planned drug strategy and comprehensive spending review, because in lots of ways these things are all interlinked with each other. So I'm not sure what the level of knowledge on the call is around drug and alcohol treatment services, but just to let you know that the commissioning of drug and alcohol treatment services is a responsibility of local authorities, and the money comes down through the public health grant. And each local authority in the South East has got drug and alcohol treatment services, and they'll be commissioned and configured based on need of the population. And providers are either third sector or NHS, or a combination of both. And broadly speaking, drug and alcohol treatment services offer a range of services to the client group, from information and advice, prescribing opioid substitution therapy, or OST, to opiate users. Most typically that'd be methadone or buprenorphine. They provide needle and syringe programs, support groups. Some of them provide outreach workers. Some have dedicated criminal justice staff, and they provide either community detox or residential inpatient detox, or that they facilitate that, and residential rehab. And I think it's important to remember that treatment approaches are wide-ranging, and they can be placed on a continuum ranging from harm reduction, which is about minimising the harms and risks associated with problematic substance use, to abstinence-based approaches, where people are expected to completely stop using either all substances or the substance that they may be dependent on. And I think sometimes the approach for abstinence-based can be either unrealistic or quite difficult for people that are experiencing homelessness. And I'm sure, as many of you know, that drug and or alcohol use can be both a cause and a consequence of homelessness and rough sleeping. And we know that people experiencing homelessness have higher rates of problematic substance use, but have difficulty engaging with treatment services. And I think engaging with flexible services for this particular client group, for those experiencing homelessness, it's really important for people to engage with a flexible service. But even those that have successfully engaged with treatment, there can be really distinct challenges associated with continued engagement as a result of their homelessness. Now, if you want to learn more about what's available in your local area, because as I say, the services are often configured quite differently based on need and the geographical size of the area, or how you can work or your staff can work with providers to engage people. And if you don't know who your local commissioner is or your treatment providers are, drop me an email and I'm more than happy to put you in contact with the commissioners and or providers. The Dame Carol Black review, I'm sure a lot of you have heard about this because there was a fair bit of media coverage when it was released earlier this year, back in August. But in 2019, the government commissioned Dame Carol Black to undertake an independent review of drugs. And this was to inform the government's thinking on what more can be done to tackle drug harms, including deaths. And the first part of the review was published last year, and that focused predominantly on supply and demand. The second part of the review, which was published in August this year, aims to make sure that people get the right drug and alcohol treatment and recovery services they need. And it includes a range of recommendations. I think there's about 32 in there, to government about increased funding and improved commissioning and accountability, how increased funding and improved commissioning and accountability can do this. There's a joint cross-government drug strategy that is currently being developed. It's a 10-year strategy, and that strategy will include a big focus on treatment and recovery, including work and accommodation. However, the detail of the strategy is going to be informed by the spending review. The spending review is still underway. That concludes alongside the autumn budget on the 27th of October. We're hopeful, but we're also that more money will come down for alcohol and drug treatment. However, we're acutely aware of the fiscal position at the moment, how tight it is, and with extreme pressures on the health and social care agenda. So 27th of October, the spending review, and it may take a bit of time for the detail to kind of filter down so that we can be clear on what's coming into the sector. Next slide, please, Karen. One before, that's it, thank you. So I want to talk a little bit about a national incident that I'm sure that many of you were aware of, which was an increase in drug overdoses. And I'm just going to set the context for that because it was quite phenomenal. I don't think we'd seen something to the size of these overdoses. There was a national patient safety alert. As I say, you probably heard about it in August. Prior to the National Patient Safety Alert being released, there were reports of unprecedented numbers of overdoses with some fatalities in people using drugs, predominantly heroin, in several areas across the country. And in the southeast, Portsmouth was the worst affected area. We had incidents in Thames Valley as well as West Sussex. And some of those areas, there were confirmed cases where the heroin contained isotretinoin, or ISO as we refer to it because it's such a mouthful. And that's a potent synthetic opioid. And just to highlight what was happening in Portsmouth, over a 10-day period, they had 5 suspected heroin overdose deaths. Over a 2.5-week period, this is all kind of beginning of August, the first couple of weeks of August, 2.5-week period, services reported 57 overdoses in total. There were an incredibly high number of near misses. Overdose cases and deaths reported with people who smoked heroin, which was interesting in itself because that's one of the usual harm reduction messages that we send out, to smoke it and not inject it. And the hostel and homelessness staff saved a number of lives during this period, and it really affected the homelessness population down there. And the staff were using naloxone daily and sometimes multiple times. And there were cases where people had to be given several doses of naloxone. There were silver and gold meetings stood up to coordinate the national response, and that was led by the NCA, the National Crime Agency, and OHID, or Public Health England as it was back then. There was a national incident management team that was led by PHE at the time for the regions that were directly affected, and we were meeting weekly to share information, look at the messaging and continually risk assess the situation. The OHID and the NCA have now formally declared the incident closed. After, I think, with the National Patient Safety Alert and all the work that went on in the local areas to try to keep users, drug users safe, that message really carried across, and we started to see a significant drop in number of overdoses and deaths. But it is something that we in the region, and each region, still monitors. And as a result of this incident, there was we're starting to look at the lessons learned. And one of the things that really came up in all the regions are the local drug information systems, or LDIS, as we love an acronym, LDIS as we refer to them, and the information sharing, which is the professional information network that sits around an LDIS, and I'll go into that a bit more in a minute. In the Southeast, we're reviewing our own regional protocol, and we've established a task and finish group with members of the Southeast Drug and Alcohol Network meeting to look at the LDISs across the region. Next slide, please, Karen. So, a drug alert system. I think it's worth bearing in mind kind of the term drug alert system and LDIS gets used interchangeably across the various areas. But basically, a drug alert system uses consistent and efficient processes to share and assess information and issue warnings when appropriate, so that high quality and effective information rapidly reaches the right people. And I think there's several things within that, and the key things are about the information sharing and the assessing of information. Next slide, please. So the LDIS model is, we've actually published guidance on the LDIS model, and some areas have configured their LDISs slightly differently, and that's to accommodate local need. But the model's intended to respond to immediate risk. It's low cost, it's low maintenance, and it's a multidisciplinary system that uses local expertise and resources. It's actually separate but complementary to the protocol used by the OHID regions and the national team. to assess drug intelligence and where needed, issue national briefings or alerts. Now, these are the components that are on the screen at the moment are kind of the key components that we would expect from an LDIS in a local area. So it's the DPH has responsibility, that there's governance arrangements in place. Ideally, we would like an LDIS coordinator. There is a panel that looks at the information, assesses the information when it comes through, mailboxes and templates. And the templates are very much for people that are in the professional information network, which I'll talk about in a minute, that when they encounter a situation, they can fill in a form. It's a one side of an A4, send it to the LDIS coordinator, who takes it to the panel, and it's reviewed. Communication, dissemination and media protocols in place, and professional information network, or the PIN. Yeah, if we can just stay on that slide for a minute, thanks, Em. Karen. I think one of the things that is we all need to be mindful about is when information is shared is at times there can be a tendency to actually send an alert out straight away. And we've had cases, not just in the southeast, but in other regions as well, where an alert will go out and say it's fentanyl, for example, which is an incredibly strong substance. You find it a lot in America, not so much over here. And it's actually not fentanyl because it's not been confirmed by a lab. And what can happen is if you keep sending alerts out, they become pointless. People stop paying attention to them. And so it's really important to actually assess the information that comes in. Has it been validated? Is there kind of lab reports to confirm that a substance has been contaminated, or is it one of the unfortunate examples that we see time and time again where, you know, somebody just took too many drugs, or they took drugs that were stronger than what their tolerance levels could tolerate. And so I think having a system in place where there's actually processes around looking at the information, where did it come from, what's it telling us, has it happened somewhere else in a neighbouring borough or in a service on the local area, and gathering that information to actually have an informed picture of what's going on. Next slide, please, Karen. The Professional Information Network, if you remember the slide I showed with the two circles, you have the LDIS kind of in the middle and then the PIN that sits around it. And the Professional Information Network is basically professionals like yourselves, like your staff, who are likely to encounter working with people who are likely to encounter new or potential or potent, adulterated, contaminated drugs. And the purpose of the PIN is simply to share the information, experience and knowledge that will then help inform any alerts or actions that's needed by the LDIS. Now, it was interesting with Portsmouth. I'm just going to go back to that for a tick, because they had, they very quickly set up a multi-agency meeting. It had the police, it had hostel staff, it had the Director of Public Health, the alcohol and drug treatment staff, as well as other public health colleagues. And it was all about sharing the information, assessing what needed to be done. And part of their media protocol was they followed the national line, which was, you know, sharing harm reduction messages to people. They contacted all their drug users that they could contact and, you know, telling them to use safely, use with somebody else, those kind of things. So it was by all the people coming together that had this information, that we actually got a pretty accurate picture of what was happening down in Portsmouth, as well as the other regions where this was impacting on. And the PIN feeds the local information and sends an LDIS form. As I said, it's one pager to the LDIS. They act as a checking mechanism, monitoring whether a similar issue has been noted by other PIN members, and they cascade alerts to specific target audiences of professionals and service users. And I think, you know, sometimes, you know, in conversations I've had with people working in hostels or even the ambulance service, for example, they will have information that actually can help inform what action's needed. So it might be that somebody overdoses in a hostel, and one of the things that the hostel staff notice is that there might be residue of drugs laying around, for example, and it mixes up differently, or it changes colour when it's cooked. And all those bits of information, if they're fed into the LDIS, can actually help inform the decisions on what needs to take place next. Next slide, please, Karen. So I was trying to think when I was preparing this presentation of how to kind of join all of this together, because I think some of these topics, you know, I could spend half an hour talking on each topic alone. And then I thought, actually, you know, we've kind of got policy, we've got money, we've got drug treatment systems. And then looking at how does that all link into, you know, to the national incident and the sharing of how we can improve the local systems and improving health outcomes for people. And I think one of the key things that runs through all of this is the information sharing. If you're not already a member, or your staff or your organisation is not represented on the local PIN, and you would like to be, and I would encourage you or your organisation to be, I think the first thing to do is to contact your local commissioner. And as I say, if you don't have their details, drop me an email and I'll put you in touch, because everybody that works with this client group potentially has information that can help prevent harms, including deaths. The other thing that I would encourage you is to understand what the referral pathways into treatment are for your local areas. Providers are really happy to actually explain their services to people, and would certainly welcome your input into, you know, if you're working in a hostel, if you're working with the homeless population, how you can support to engage them in treatment. And then if they engage, how to keep them in treatment. And the final thing I would encourage you and your staff to do is talk to people about wound care, because I think it's one of those things that we often forget about, or we don't pay as much attention to. So even people who are using needle and syringe programs, the rates of sharing needles remains high, and the rates of bacterial infection are actually really common. So at one end of the spectrum, we've got the fatalities that I talked about with ISO around the national incident. But at the other end of the spectrum, we also have IGAS, or invasive group A streptococcus bacterial infections, where people have to have limbs removed, or they have infections that don't clear up. And I think it's really important that, you know, that if we're working frontline, or we're in a position to engage with this client group, that we actually talk to them about, you know, have they got any sores that won't heal? because they may not actually feel the pain if they've got an infection because of the drugs that they're using, which on the one hand can be a great painkiller, but on the other hand is causing infection in their bodies. And I think there's sometimes we all get a little bit complacent around having those conversations and talking to people about, you know, are they having trouble injecting? If they're having trouble accessing a vein, is it because there's an infection in there? So I think that is one thing that I would strongly encourage you or your staff to actually have those conversations if possible. And next slide, please, Karen. So what I've done is I think these slides that have been sent out or are going to be sent out. So there's just some resources there. The shooting up infections among people who inject drugs in the UK is really interesting. It comes out annually. I think the new one is due out in the next couple of weeks or next month, hopefully. And that's about the infections, not just eye gas, but also hepatitis B, hepatitis C, HIV. And again, it's about having those conversations with people about, you know, have they been tested for hepatitis B and C? Have they had a vaccination for hepatitis B? You know, are they open to treatment for hep C? And then there's some, also with the wound care, there's some additional information in that resource pack. And finally, my email address at the bottom if you know, want to contact me outside of this meeting. And next, and that's it.
That's brilliant. Thanks ever so much, Tracy. We've got a few kind of comments and questions in the chat, so I'll go there first.
Yep.
Anna Hode, who's Anna, you could introduce yourself, Anna, if you'd like. But, do you want to come in?
Yeah, hi everyone. I'm Anna Hode, one of the health protection nurses in the Surrey Sussex Health Protection team. So we're the team where we deal with notifications of infectious diseases, and kind of feeding into what Tracy was saying, we quite often actually get notified of people who inject drugs and homeless members of the community who have an invasive group A strep infection. And we quite often have to work with the specialist teams in various areas to try and, you know, assess any contacts and any shared drug paraphernalia and look into a potential kind of source. So it would be really interesting to see if and how we can feed into the network, really.
Yeah, thanks, Anna. I mean, as I say, we're currently doing some work with all the areas in the southeast around their elders and their pins, and I think that would be really helpful once we've got a complete list of each elders. As I say, some areas have got a really strong elders at the moment, and some are still under development. But I think what would probably be helpful for you and your colleagues is that once we've got a list of all the coordinators, that we send that to you. And then when you get notified of these infections, if you let them know. So I'll make a note to keep you updated on the elders coordinators list.
Brilliant. Thanks, Tracy.
That's brilliant. Thanks, Anna. And Gillian has asked if people develop sepsis as a result of poor wound care secondary to IV use, is it linked to drug-related deaths?
Drug-related deaths, when we define them, and that they come out from the so every year the Office for National Statistics releases the stats on drug misuse deaths, and drug-related deaths in that instance are actually defined as if the coroner rules that a substance was involved. I'm not sure if if they develop sepsis as a result of poor wound care.
Go on, Gillian, do you want to come in?
Yeah, that might be better.
I was just wondering whether actually the numbers of drug-related deaths are actually higher than we think, because I know that the drug-related are usually recorded against where the coroner has recorded, high levels of drug toxicity. But I just wondered, in my past experience in drug and alcohol services, sometimes, kind of poor wound care quite often led people to be admitted with, quite severe systemic infections, developing sepsis, and in some cases died. And I just wondered whether that's also recorded as a drug-related death, because quite often the initial work was as a result of sharing needles or injecting. And so I just wondered whether the figures are skewed a little bit.
Yeah, they could be. I mean, I can look into that a bit more for you, Gillian. It would be interesting to see if that does skew it a bit.
Yeah, no, that'd be interesting.
Thank you.
Can I just, I can't put my hand up because I can't do the little
go on,
things, Karen. I'm just thinking that's about proper death certification, really, because the primary, I think there's like A and B parts to it.
Yeah.
So the primary part would be sepsis or so on, but the B part would be drug-related death. So you are able to develop that complex picture of how that death came about. So there might be an issue, but it's probably down to poor death certification as opposed to being incorrectly labelled. I would suggest.
Yeah.
I think, Jason, you've got your hand up.
I do, Tracy. Well spotted. Thank you very much. I just wanted to come back on your comment, Jill, because I think it's really well made, and I think it ties into the conversation we were having last time we met about safeguarding adult reviews. And I recall a conversation I had many years ago with one of the doctors at Luther Street Surgery, who was jumping up and down saying all these alcohol-related deaths among these homeless people, and it's the blooming comorbidities that they've got because of all the other problems they've got going on in their life that get recorded. And the alcohol doesn't get mentioned, but that's the thing that's killing them. And I think your point about sepsis is really important. It's kind of a way in, but really the learning about what do we need to do, that's going to come from a safeguarding adult review. And otherwise, we're absolutely dependent, as you said, Tracy, on kind of what the coroner's verdict is as to what the death. And some will make that connection much more clear in their kind of narrative verdict or their verdict than others. So I think for me it really kind of hammers home the importance of considering each of these deaths as a self-neglect, a safeguarding adult review, and a cause for investigation.
Yeah, absolutely.
I strongly would encourage, because I sit on some of the staff subgroups, for people to refer drug and alcohol related, particularly where there's those elements of self-neglect with regards to wound care and kind of difficulties with services managing to retain people in treatment rather than the person having difficulty engaging, to refer in as SARS, because personally I don't think that we focus enough on SARS of homeless people with substance misuse. I've got to apologise, I've got to dip off to another meeting, which is a shame because it's fascinating.
Thanks.
Thank you.
Vicky, do you want to say any more about the research and the links around the emotional stuff?
So just in relation to some work that I've listened to from specialist nurses who've been looking after homeless people, about not underestimating sometimes the emotional and psychological almost bonds is probably the wrong word, but between the person and their wound, and that can be a really complex area, and it's not just as simple as trying to get people to have wound care and have treatment. There's quite a lot of therapeutic work that needs to go along with that, like getting people to look at their wound, to think about all the aspects of what's led to it, and almost an attachment that can be formed between the person and their wound. So there's some it's just not underestimating the complexity of trauma and physical healthcare as well. So yeah,
that's really helpful. Thank you. Do you have any links that we can share for that?
I was just about to say I'll have a look and see if I can post something in the chat.
Thank you. Daniel.
Sorry, I was just going to ask, in relation to wound care, it's something that comes up quite a lot with our kind of long-term repeat homeless cohort. And I think a lot of that great work that's being done with people seems to be being done through district nursing teams who are quite inaccessible to people who are without accommodation. I was wondering if anybody else from any other areas been doing anything interesting around kind of safeguarding and making services more inclusive to that cohort.
Do any other areas have kind of specialists, nurses for this in their kind of specialist nursing kind of healthcare teams in this area? Can't see who. Jen. Hi, Jen.
Hi, I'm Jen. I'm a clinical psychologist working with Oxford Health in the out of hospital care team. And I have worked in Westminster and Lambeth with the homeless population. And I know that Lambeth in particular have got an amazing high intensity nursing team who reach both into the hospitals but also at day centres, and they do amazing work, and they totally get the kind of emotional stuff around all of the health problems that these guys experience. So for me, they're kind of like the gold standard, but I don't know anywhere within kind of outside of London.
Yeah, I know Brighton and Hove's team have got stuff. Jane, you've probably got quite a good handle on some of these. Do you want to come in?
Yeah, no, there's a lot of specialist nurses around the country, very often working in multidisciplinary teams, and that's the best model really, to be part of a multidisciplinary team. So Eastbourne, for instance, the Rough Sleepers Initiative fund a health team with mental health workers, specialist nurses, social worker, who work closely with the outreach team doing in-reach and outreach. And also now there's also work going on to expand that team with contracts from NHS. So how do you build capacity and sustainability? And in Oxford, there's Luther Street Clinic, which is a multidisciplinary team. And of course, in Brighton, there's the Arch team. And and then there's across the country. I mean, I could go on and on, but I won't. But if people are interested in it, I can put them in touch with some really good models, and Bradford, Bevan Healthcare, and also linking up now around with hospital discharge as well is absolutely key. And that's in Bradford, Brighton, Bristol, lots of areas, Oxford, but also with wound care. So the Queen's Nursing Institute runs the Homeless Health Programme, and they're doing some work specifically around wound care and homelessness with Dr. Jamal Geraghty, who's a nurse specialist in wound care. And we've also developed some e-learning on different issues, and one will be there's one on street nursing and what's needed, so to give some really good guidance. But we're also looking to work with Jamal around wound care and developing some e-learning. So yeah, I can share the link into the Queen's Nursing Institute, because they've got loads of resources. And we're just going to do e-learning on nutrition. They've got guidance updated on nutrition. So yeah.
Thanks, Jane. Daniel, did you want to come back on that?
Yeah, sorry, just to in my experience, it's kind of working in rough sleeping. I've seen some of these more specialist services and the excellent work that they do. I'm very envious. And I do know there's some great projects out there, but I think it was more for kind of areas like ours where unfortunately we haven't been successful in fund for primary healthcare nurses to be providing specialist services. How do we get kind of statutory provision really to make sure that that without a specialist service there isn't a gap in provision. Am I making sense?
Yeah, no, absolutely. And we can certainly have a look and see where similar areas that don't have access to that kind of funding, what kind of mechanisms they've used to tap into kind of standard healthcare, and how they've managed that in those cases. So we'll see what we can find on that, Daniel. Any other questions before Tracy or others before we move on to the general update? No. Thank you all. That was brilliant. And thanks ever so much, Tracy, for coming along to do that. That was fabulous.
Right. Thank you.
Jane, are you happy to give us a bit of an update from the department? I'm not going to say